Okay, I think we can start. Good morning and welcome everyone to the Department of Medicine Grand Rounds. Then as of this month, we have combined Grand Rounds with St. Joseph Hospital. So having all the Department of Medicine as one Thursday morning Grand Rounds, which is great. Today we have three amazing chief residents completed their chief residency at one of our Hamilton Health Sciences hospitals. Our speakers today is Dr. Rauda Al Dhaheri. He's a PGY3 in internal medicine, completed her training at the United Arab Emirates University, and she's going to carry on with her fellowship in respirology here at McMaster, so we're lucky we're going to keep her. And Dr. Dalal Al Faraj. Dalal is a PGY3 in internal medicine and completed her medical school at Kuwait University, and she's carrying on with her fellowship in gastroenterology. Luckily, she's not going too far. She's going to UFT. And Achieng Tago is a PGY3 in internal medicine, completed her medical school at University of Manitoba, and was staying with us at McMaster to complete her fellowship in cardiology. These fantastic three well-accomplished chief residents will be speaking to us about an important topic, challenges of dual antiplatelet therapy following percutaneous cardiac interventions, and they're supervised by Dr. Haroon Youssef, who's an assistant professor in GIM here at the Hamilton General. Without further ado, I'll pass it on to our speakers.
All right, thank you very much for that kind introduction, Dr. Azam, and we'll just get to the next slide over. And before we get started on the topic, we're going to start with a land acknowledgement. So we at Hamilton Health Sciences recognize that the lands on which we provide care are the traditional territories of the Mississauga and the Haudenosaunee peoples. For thousands of years, the first people sought to steward the precious resources and share this land with others. These territories are the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between nations to peaceably share and care for the lands around the Great Lake. Next slide, please. So as Dr. Azam mentioned, our topic today is challenges to dual antiplatelet therapy following percutaneous cardiac intervention. So we have a few objectives for you. Number one, to identify some challenges to dual antiplatelet therapy following PCI. Number two, to summarize the evidence in management of dual antiplatelet therapy following PCI. And then number three, to demonstrate how this evidence can be used in various clinical scenarios and to be able to utilize the concepts discussed during these rounds to better manage your patients who may be going through some of these scenarios. Next slide, please. So percutaneous coronary intervention, or PCI, can be done for many indications such as acute coronary syndromes and high-risk stress testing. There's an indication to start dual antiplatelet therapy, or DAPT, following PCI, but what happens in situations that complicate DAPT administration? Next slide, please.
All right, so good morning, everyone, and thank you, Dr. Azam, for your kind introduction. So we'll start our talk with one of the challenges that most of internal medicine or cardiologist staff may face during their practice. And I will start my talk with a clinical case for Mr. M, who is a 72-year-old man who has medical background of diabetes mellitus, dyslipidemia, and a smoking history. He presented with acute chest pain in the context of anterior STEMI. His home medication include aspirin, metformin, and statin. He has no history of contrast allergy. He underwent primary PCI to LAD with one drug-eluting stent. He was started in dual antiplatelets, including aspirin and Clopidogrel, for 1 year, as well as statin. 5 days following his cardiac catheterization, he reported to the emergency department as he developed generalized erythematous rash. At that time, the impression that this patient likely developed Clopidogrel hypersensitivity, given his history and background, and that was the only new drug he has received. And that was the big challenge, as the patient was recently stented with a drug-eluting stent. And the question was, what would be the best action in such situation? We choose Clopidogrel, or we focus on Clopidogrel because it's a common, or like it's an oral antiplatelets widely used in the management of patients with cardiovascular disease. In addition, long-term administration of Clopidogrel with aspirin is recommended after drug-eluting stent placement for prevention of late stent thrombosis in many patients. Development of hypersensitivity reactions after Clopidogrel administration is a recognized complication and present difficulty in management, especially if you are not, if you cannot use other like antiplatelets with this patient. Among the articles and case reports in the literature, I found this article, which was published in the American College of Cardiology. Interestingly, this study and articles was done in Toronto and Hamilton, mainly at St. Michael's Hospital in Toronto. It talked about the characterization of Clopidogrel hypersensitivity reactions and management with oral steroids without Clopidogrel discontinuation and even with desensitization. And I chose this article because I found that most of like CCU staffs at Hamilton General use these articles while managing or treating people with Clopidogrel hypersensitivity or allergies. The main objective of this study was to characterize Clopidogrel hypersensitivity and describe its successful management with oral steroids without Clopidogrel discontinuation or even desensitization. There were around or total 3,877 patients who underwent PCI during the period from 2006 to 2010 at St. Michael's in Toronto. 62 represented 1.6% of these patients had developed a proper and definite Clopidogrel hypersensitivity. 79 of these 62 had manifested with generalized rash, whereas 16 manifested as focal rash and 5% presented as angioedema or urticaria. As you can see on the table, there was like many variables and characteristics described, and it was described for people with a Clopidogrel hypersensitivity and the entire PCI cohort patient. The main age found to be 62-year-old. Majority of them were male, with 71% of them were male patients, and 35% had reported prior drug allergy. What they did with these patients, or the intervention was they prescribed a 3-week tapering course of oral prednisone starting at 30 milligram twice per day for 5 days, followed by a decrease of 5 milligram per day every 3 days for 15 days. And they also prescribed diphenhydramine 25 to 50 milligram every 6 to 8 hours for pruritus if present. And they followed this patient like almost like with a median follow-up of like 1 year up to 1.5 years. And this is like, you can see the difference, the different manifestation of Clopidogrel hypersensitivity. As I said, like majority of them like were all kind of generalized emphysema. So as in the right upper slide, you can see generalized emphysema affected the chest, abdomen, and upper lower back, and with the variation and the severity. And the lower slide on the right, you can see the localized rash, which can be like affecting the face with discoloration and erythema of the face. It can affect the soles or the palms, and they can affect even like any area of the body with a localized rash. On the left side, you can see the usual or the common manifestation of any allergy, which includes urticaria or even angioedema. But like as I mentioned earlier, it's where like a minority of patients had developed this kind of manifestation. So what were the observation at that time? There were no significant difference in cardiac risk factors, concurrent medications, procedure variables between patients with Clopidogrel hypersensitivity and the entire patient's cohort undergoing PCI during the study period, except for the use of drug-eluting stents. They found that like there were complete resolution of absent reaction, and this was observed in like 61% patients, which is like 98%, with a short course of oral steroids. All patients with clopidogrel hypersensitivity were able to continue clopidogrel for the recommended minimum duration without recurrence of clopidogrel hypersensitivity after treatment with oral steroids. And when we say the minimum duration, we're talking about the 4 weeks after prenatal stent and the total 12 months after drug-eluting stent. All patients were continuing on aspirin, 81 milligram per day after completion of clopidogrel therapy with no concerns or issue. They continued, the researchers or the physicians were continuing following the patients for a median of like 576 days. And during the follow, there was like 1 death, 1 myocardial infarction, and 6 target vessel revascularization procedures. And the death was due to experiencing a stroke and happened like around at the 8 months of follow-up. All patients had completed the minimum duration of clopidogrel therapy, as I mentioned earlier, and none of the study patients suffered from stent thrombosis. During the study, they were concerned or they were interested in knowing what's happening in the body and what type of hypersensitivity patient developed when they have clopidogrel hypersensitivity. So all the patients who had the hypersensitivity or the skull rash underwent the punch biopsy, and interestingly, it's shown that it is a lymphocyte-mediated type 4 allergic reaction in most of the patients. So if you can see the arrowheads on all the pictures, it's more of lymphocyte infiltrates in the epidermal and dermal layers of the skin. But like always remember that there is a minority of patients who have this kind of like angioedema or urticaria, which is usually an IgE mediated hypersensitivity. They also they did kind of patch testing after the patient completed the steroid course. They did the patch testing in order to see if the patient have like a real clopidogrel hypersensitivity, and it's found and the patch testing was abnormal in 81 of tested patients with clopidogrel hypersensitivity. Interestingly, they did the patch testing to see if there is any kind of cross-reactivity among clopidogrel, taclopidine, and prasugrel, and they found that there is an evidence there is in a significant number of patients that suggests that there is a presence of a common hapten among this therapeutic class, and the patient they may develop kind of cross-reactivity. Despite this was like a good study, but like with like maybe a small population, there was as well a kind of study limitation. So the first one, that the clopidogrel hypersensitivity was observed in 1.6% of patients treated with aspirin and clopidogrel after stent placement. And this rate is that it's lower than the 6% incidence of the skin allergies reported in the CAPRI or clopidogrel versus aspirin in patients at risk of ischemic event studies. However, all patients undergoing PCI were not routinely followed for detection of clopidogrel hypersensitivity. And in addition, no information was available for patients who developed clopidogrel hypersensitivity and did not undergo PCI. The results of patch testing suggested the presence of allergenic cross-reactivity among clopidogrel, taclopidine, and prasugrel, but definite clinical cross-reactivity among these drugs cannot be concluded because none of the study patients received oral taclopidine or prasugrel. So based on this study, our resident takeaway or home messages is that clopidogrel hypersensitivity is mostly manifested as generalized lymphema occurring at median of 5 days after clopidogrel initiation. It's caused by a lymphocyte-mediated delayed hypersensitivity in most of the patient, but like remember, they can be caused by type 1 or IgE-mediated hypersensitivity. This hypersensitivity can be managed with oral steroids without clopidogrel discontinuation, regardless of the clinical manifestations. Allergic cross-reactivity with taclopidine, prasugrel, or both is present in a significant number of patients with clopidogrel hypersensitivity. So that's the end of my part, and I will give the floor to Achieng.
Okay, thanks, Dalal. So for my clinical case, we have a 55-year-old gentleman with a medical history significant for dyslipidemia, hypertension, and diabetes, who recently received a stent to his RCA following an NSTEMI. He is discharged from hospital on dual antiplatelet therapy, including aspirin and clopidogrel. However, 2 weeks after his discharge, you once again get paged and you see him in the emergency department where he presented with yet another coronary event. So the question is, what happened? Next slide, please. So there are many factors that may lead to acute stent thrombosis. For example, intrinsic causes such as inadequate stent deployment, residual stenosis, dissection, as well, medication non-compliance with dual antiplatelet therapy is the most common cause of stent thrombosis. However, clopidogrel resistance, or as it's also referred to as clopidogrel non-response, is another factor that can lead to stent thrombosis, and that's what I'm going to be discussing here. So for some biochemistry, clopidogrel is a prodrug that remains in an inactive state until it's activated by the cytochrome P450 system. There's 2 steps that lead to the formation of the active metabolite, and this ends up being about 15% of clopidogrel's metabolism. It's estimated that the other 85% of the medication is metabolized by the blood into an inactive metabolite, which doesn't overall contribute to the effect of clopidogrel. There are loss of function genetic variants in the cytochrome 2C19 system, which is also in the liver, that are known to alter the clopidogrel metabolism. For example, loss of function mutations that can lead to a decreased response to clopidogrel, and these loss of function variants lead to a higher residual platelet reactivity. Next slide, please. So there are other conditions aside from loss of function variants, which have also been associated with a high residual platelet reactivity. This includes things such as elevated BMI, which some studies actually show that there have been a positive association with a failure to overcome a high residual platelet reactivity in individuals with an elevated BMI. Other conditions include diabetes and heart failure with a reduced ejection fraction. Therefore, there must be some interplay between genetics and environmental factors that lead individuals to become clopidogrel non-responders in patients that have a high residual platelet reactivity. Next slide, please. So this review article defines high residual platelet reactivity as the high level of platelet reactivity that occurs following a loading dose of an antiplatelet, of which the clopidogrel is often the most studied. So as noted above, the HRPR has been associated with clopidogrel resistance, and there are different modalities of measurement, including light transmission aggregometry, or LTA, which is often seen as the gold standard, as well as newer methods such as vasodilator-stimulated phosphoroprotein phosphorylation, or VSAP analysis, and the newer Verify Now P2Y12 bedside assay. Next slide, please. So this leads to the question, is there actually a clinical significance to clopidogrel resistance as defined by high residual platelet reactivity? In other words, does it actually lead to more events? So it's been found that in patients with a high residual platelet reactivity after receiving a loading dose of 600 milligrams of clopidogrel, they had an increased risk of stent thrombosis 6 months following PCI. Similarly, in STEMI patients who received PCI, the higher the platelet aggregation as assessed by LTA, the higher the chance of having a repeat ischemic event in 6 months. Similar findings have also been seen in individuals who have an elective PCI procedure done. Next slide, please. This slide talks about a meta-analysis that was done with the goal of summarizing the evidence of the clinical risk that is associated with a decreased response to clopidogrel. So out of the 15 studies that were included, 151 patients, or 15% of patients, were defined as clopidogrel non-responders, as determined by LTA, and had an ischemic event when compared to only 4% of responders, which was roughly 121 patients. Next slide, please. So the question now becomes, should we be routinely testing our patients for clopidogrel resistance as based on the high residual platelet reactivity, since it's been shown to have that association? Going back to this review article, although the LTA is considered the gold standard for measuring the high residual platelet reactivity, there is no established gold standard test in terms of defining actual clopidogrel resistance. This article also notes that the routine measurement of assays assessing the HRPR are not recommended. However, there is a noted value in measurement of assays for individual patients who are either very high-risk PCI or who have had a prior presentation of stent thrombosis. Next slide, please. So what do the guidelines have to say about this? In the Thrombosis Canada Clopidogrel guidelines, there is an acknowledgement that genetic polymorphisms may lead to reduced benefit of clopidogrel. However, they recommend against specific testing. So they seem to be in line with that review article that I just summarized. Next slide, please. According to the CCS guidelines, intensification from clopidogrel to Percutaneous or ticagrelor is recommended in the following situations. So number one, patients initially treated with clopidogrel who are admitted with a thrombotic event, such as stent thrombosis or an acute coronary syndromes. And then number two, patients who are known poor metabolizers of clopidogrel. Next slide, please. So back to our clinical case. We have a 55-year-old gentleman who had a medical history for dyslipidemia, hypertension, and diabetes, who had a stent to his RCA after an end-stemming. So in this situation, he comes back with a stent thrombosis, and we think that the situation is likely due to clopidogrel resistance. So what do we do now? Next slide, please. Okay, so the bottom line from the studies that were reviewed are up to 45% of patients have clopidogrel resistance. However, despite this, routine testing is not currently recommended. And even though there are ways to test for a high residual platelet reactivity, at the same time, there is no gold standard to test for what level of high residual platelet reactivity actually indicates clopidogrel resistance. So therefore, routine testing is not currently recommended. However, intensification of therapy is recommended in certain situations, specifically in situations where a patient is high risk or we know that they've had a prior event. And so my takeaway from all of this it's very hard to assess which patient is going to be resistant to clopidogrel without them having a prior event that may indicate this. Therefore, it's always good to just have a really high index of suspicion that this is something that exists and it's something that can occur in up to 44% of our patients who are undergoing PCI. And I will hand the slides over.
Hi, everyone. So my part's going to talk mainly about the duration for the dual antiplatelet therapy. My four objective in this part, basically to summarize it quickly, the CCS in 2018 about the duration for dual antiplatelets for both elective PCI versus not. And also I'm going to talk briefly about the DAPT trial and the stop DAPT trial. And also the last part is going to be quickly talking about risk calculator as a DAPT. You can use it in your clinical setting. Next slide. So the case is basically, I have a 60-year-old male who actually have a history of non-ST elevation MI. He came to your clinic for follow-up assessment and regard his duration of dual antiplatelets. He underwent the PCI with a drug-eluting stent to his LAD last year. He was taking his dual antiplatelets for almost 1 year. He denied any previous admission for bleeding, and his past medical history is significant for his diabetes, CKD, and reduced ejection fraction. His current medication, apart from his heart failure medication, is Plavix 75 and aspirin 81. So what's your option? Are you gonna stop both dual antiplatelets? Or are you gonna just continue with single agent lifelong? Or you might extend actually his dual antiplatelets up to the 3 years. Next slide. So basically, this is from the guideline from CCS in 2018, and also you can find the same one, diagram on Canadian thrombosis, just with some modification in regard to the dose of ticagrelol. So basically, if your patient underwent a PCI for ST elevation MI and non-ST elevation MI, the recommendation is to continue the dual antiplatelets for 1 year. It's either by aspirin ticagrelol, which is the preferred, over the Plavix. And after 1 year, you should determine your patient risk factor for the bleeding. If you find he is a high risk, basically the recommendation is to continue with a single agent, aspirin or clopidogrel. And if you find your patient basically he's not a high risk of a bleeding, he might be benefit from continue the dual antiplatelets up to 3 years. And about this risk of bleeding, I'm going to talk about what's the criteria for the risk of bleeding for your patient. Next slide. If your patient underwent elective PCI and you find him basically he's a high risk for bleeding, the recommendation is to continue the dual antiplatelets for 1 month if he has a metal stent, and 3 months if he ended up doing a drug-eluting stent, and then later on you continue with a single agent. However, if he was not at the high risk of a bleeding, you continue the dual antiplatelets for 6 months using aspirin and the clopidogrel. And then later on, you assess him after 6 months. And if you find basically he's a high risk for clinical and angiographic feature, which I'm going to talk about those later on, if the answer was yes, you're going to extend his duration up to the 3 years. If the answer was no, basically after 6 months, you just continue with a single agent. Next slide. As I mentioned about high risk clinical and angiographic feature versus the bleeding, I will start with high risk for thrombotic event, starting by talking about the clinical. So if your patient have an MI previously or any positive troponin with non-ST elevation, also if he's known to have a diabetes where he is actually on the treatment oral versus insulin, or you find your patient, he has a CKD with creatinine clearance less than 60, any previous history of stent thrombosis, and if he found to be a current smoking, all of those clinical features actually put your patient at risk of having a thrombotic event. Talking about the angiographic feature, which is going to be mainly for cardiology, because they are the one who are going to give you the summary of the PCI. So basically, if he ended up having a multiple stents, more than 3 stent, and more than 3 lesion has been identified, he's at risk for a thrombotic event. Also, if the lesion has been long, more than 16 millimeter, and if also the lesion has been found on the bifurcation, and if left main versus the proximal LAD has been stented, or he ended up having a multiple PCI. So clinical and angiographic, what I mentioned about, all of those put your patient at risk for thrombotic event, and you would rather extend the duration. Next slide. What about the patient who actually have a high, who actually ended up having a bleeding risk? So who actually those patients who are going to be ended up maybe with this complication? If your patient have started already on oral anticoagulation in addition to the dual antiplatelets, yes, he's at high risk for bleeding. If his age is 75 and above, if he had actually anemia with hemoglobin less than 110, and if his body weight less than 60 kg, if any previous hospitalization with a bleeding in the last year, any previous stroke with a bleeding, and also if your patient actually taking NSAID versus steroid for another medical problem, all of those are the risk factor to increase your bleeding risk. And in those patients, you would kind of you're not gonna extend the dual antiplatelets. The next slide. So basically, this is kind of a trial has been conducted, I believe, from 2009 till 2011, and the article has been established in 2014. They were talking about the 12-month versus the 30-month of the dual antiplatelet therapy after the drug-eluting stent. So the sample size was almost 10,000. It's including 18 years old patient who ended up doing a PCI. And the intervention, basically, after 1 year of the dual antiplatelets, those patients has been randomized 1-to-1, like 5,000 versus 5,000. The 5,000, basically, they were taking a single agent, aspirin, and with a placebo, and the other group, they were taking aspirin plus Plavix. They mention here basically one of the thienopiridine, but Plavix is the one example of those group. And the comparison, basically, they were looking at stent thrombosis, what was the adverse cardiovascular effect, and also the rate of moderate to severe bleeding. Next slide. So the study outcome, starting with stent thrombosis and the major adverse cardiovascular and the cerebrovascular event. From the stent thrombosis, there was a significant benefit from extended your dual antiplatelets up to the 30-month. And talking about also the cardiovascular risk factor, also there was a benefit from extending your dual antiplatelets up to the 30-month compared to the placebo. Next slide. However, looking to the bleeding risk from 12-month versus the 30-month, they were using the criteria from GUSTO for severe moderate, and also they were using a BRC type 235, comparing GUSTO for severe and type 5, basically placebo versus the 30-month, they were both fatal and there was not significant. However, from moderate, talking about the moderate risk of bleeding, there was a significant evidence that if you extended your dual antiplatelets up to the 30-month, there is a risk of moderate bleeding that has been identified in this study. Next slide. So to conclude from this study, comparing the 12-month of dual antiplatelets versus the 30-month of dual antiplatelets was associated with a low rate of stent thrombosis and the major cardiovascular event. However, also extending the dual antiplatelets was associated with a higher rate of moderate bleeding. So kind of take-home message to the resident, use also your clinical judgment and also use case by case when you assess if you're going to extend versus not. Next slide. I found basically the DAPT decision tool is a quite benefit in regard like giving you an idea what to do next. So basically the DAPT decision has been applied during this trial, and this DAPT tool actually is kind of more help you to predict if your patient gonna ended up needing extended dual antiplatelets. It's kind of assessing your ischemic versus the bleeding risk. And from the DAPT score, basically, if you have a MedCalc app in your phone, it's gonna be easy. So you can do it like in less than 1 minute in the clinic. So the DAPT score has been including patient age, any previous history of heart failure, what actually the MI at the presentation, what type of the stent, and if your patient is diabetic, smoker, and the age of 75 and above. As you get like score 2 and above, that means it's more a favorite of you're gonna extend the dual antiplatelets, as it's gonna be more favor of ischemic prevention. However, if the score was lower, it's going to be more a favor of a bleeding risk, and you would not rather think about extending the dual antiplatelets. Next slide. So I mentioned to you already the summary of the DAPT. If your score was high, that means you kind of more a favor of you're going to extend the dual antiplatelets. However, if the score 2 or less, it's more favor of not to extend. But just to let you know, this is just, you have to use also your clinical judgment on top of the score. Next slide. Also from JAMA, there was an article in 2019. They were looking basically of 1 month of dual antiplatelets, followed by the Clopidogrel versus the 12-month of dual antiplatelet therapy. The main objective of this study basically to see the hypothesis if this is like the 1 month is not non-inferior to the basically the 12-month. The study basically is in multi-center and it's randomized. And the intervention basically, they include just almost the total size of this study was 3,000 patients. 1,500 in one group and 1,500 in the other group. They were looking basically the one after 1 month, basically they were looking to continue just with a single agent, which was the Clopidogrel, versus just to continue up to 1 year and to see if there is a difference in terms of that. Next slide. From this stop DAPT trial, so basically the major outcome that I will talk about is the primary endpoint. We were looking for the cardiovascular death, myocardial infarction, and the stent thrombosis. The finding basically from the primary endpoint, it found basically 1 month versus the 12-month, there was non-inferior to that. Looking to the major secondary endpoint, also it was non-inferior, like 1 month is non-inferior to the 12-month. However, by the bleeding as a complication, the superiority came to the 1 month versus the 12-month. Going to the next slide. So kind of a conclusion of this trial, although the size is like almost 3,000, but they actually approved that the 1 month of dual antiplatelets is non-inferior to the 12-month. In terms of cardiovascular endpoint, however, it was superior to the bleeding. Still, due to the study limitation, additional research will be great. And also there was, next slide, there was 2 additional trial has been conducted looking for the same, almost like reducing the duration for dual antiplatelets. Like the study was basically, I'm just gonna talk briefly, the SMART choice in 2019. A 3 month of dual antiplatelets versus the 12-month also showed there was non-inferior to continue with, it was non-inferior and regard the major cardiovascular event as a prevention. And also the Twilight study, it's also, the size was 7,000. And also it showed basically, it's non-inferior too. Next slide. Going back to the clinical case. So in this case, because if we think about the clinical feature and the angiographic, and if you use the DAPT score, this patient is favorite of, you're going to continue the dual antiplatelets 2 to 3 years. And that's it. If anyone have a question, we're happy to take them.
Thank you so much for this overview of those challenging situation that probably we all face, as much as this is pretty common. Haroon, do you have any additional comments before we go into the Q&A? And if anyone has a question, please put it in the Q&A section. If you have a comment, you can put it in the chat. Or if you want to speak up and ask your question in person, please raise your hand and I will bring you in as usual. Haroon?
Yeah, that was a great overview and lots of challenges we deal with, not just in GIM, but cardio, GI. These are things that apply to all of medicine and subspecialists because these medications are so common. My main comments in the first 2 cases, I was thinking, I'll just stick to ticagrelor to try to avoid those issues that happen with Plavix. And the other comment I had was, I know that there's been studies to show in East Asians that they tend to have more platelet reactivity when start on Plavix compared to Western populations, but I don't think it translates into worse clinical outcomes on Plavix. So like Achieng was talking about, it's not just genetics. There's a complex interplay between genetics and lifestyle as well.
Thanks, Haroon. There are a couple of questions about actually the comment related to, I think the Dr. Percutaneous asked about cross-reactivity with ticagrelor. I'm assuming about the sensitivity, and another question saying, why don't you just go with ticagrelor, right? I don't know if anyone wants to take those 2 questions as I bring in people who want to ask in person.
Sure. So when I reviewed the articles and the literature, basically because the Clopidogrel and have like a different structure compared to ticagrelor. So they don't have like a cross-reactivity because they are different structure. Whereas like ticlopidine and prasugrel, they share the same structure with or similar structure as Clopidogrel. There are some case reports, I think I read one was published maybe in 2015 or 2014, which showed there's no kind of like evidence of cross-reactivity with ticagrelor because if they were like different structure.
Thank you, Dalal. Dr. Holbrook, please go ahead.
Thanks, Khaled. And thanks very much for the rounds. That was excellent, excellent topic. I just wanted to make a couple of points, and one of them was exactly on that issue that ticagrelor is the only non-thionopurine in this group. So theoretically, it has less cross-reactivity, but my understanding is the evidence is just less well developed, and that will come out. A couple of other cautions I should mention, just on the very pragmatic side. We moved away from ticlopidine to clopidogrel years ago for a reason. Ticlopidine was the first non-aspirin antiplatelet, had a lot of, not maybe the first, but one of the first, had a lot of adverse effects, including hematologic. It is so rarely used that there's regularly shortages. Several of the brands have been discontinued. Similarly with Percutaneous, because it basically lost in the head-to-head battle with ticagrelor. So there have been shortages. So my plea would be, before you discharge anybody with an acute event, we have had several disasters happen because people did not follow through to be sure the patient would pick up their medication. So be sure to have your pharmacist figure out, whether the drug's available, be sure you've got the LU code. You should also mention that there are desensitization protocols. Obviously, that would involve probably another service, but for the more severe allergies than just rash, there are still some indications of keeping the person on clopidogrel. And I think even Up to Date has several protocols. It's a gold mine for almost everything, including here. And my final point is, when we talk about clopidogrel resistance, it's the same with aspirin resistance, or in quotes, any other drug resistance. The most common cause of a clinical event related to a medication that should not be happening that you might expect is non-compliance. And you have to really go over and try and investigate whether the patient has actually been taking the medication. That's one of the advantages of aspirin. It has a long half-life, so you can miss a dose, and not lose the effect. But clopidogrel and the others are shorter acting. Thanks, Callan.
Thank you so much, Anne, for those very important comments. I'll bring in Dr. Levine, who is also like to comment. In the meantime, Dr. Pertani is commenting on the DAPT score, and it's a nice app. I actually just downloaded the American Cardiology Association app as well. Yeah,
can you hear me now?
Yeah.
Okay. So there were two things that I thought were incompatible with each other, and I'd like to figure out how you reconcile them. There's the 44% resistance that you reported, and yet the STOP2 study, which says you take 1 month of dual, and then the next 11 months are just clopidogrel, and yet you do better. It's all, if 44% of people are resistant to clopidogrel's effects, it's like you've got 44% on nothing. And yet that group did better than the comparison group. So how does one reconcile this?
I can answer that question. So and sorry, I should have stated this. So it's up to 44%. So studies have shown anywhere from 4% to up to 44%. And exactly the comment that Dr. Holbrook mentioned, the number one thing that leads to resistance in any medication is noncompliance, which is often something that does happen. But there are up to 44% of people that can have this interplay, whether it's the genetic loss of function variant that can lead to the high platelet resistance that is associated with resistance in general, as well as other factors also. Does that kind of answer your question?
Well, yeah, partially. The reality is whether the resistance is due to some genetic or some failed adherence. The high rates of resistance, in that second study, those people are on nothing for 11 months. And yet that group did well, which that doesn't almost make any sense to me. That's all.
Yeah, well, I think that comes back to the point that does platelet resistance actually correlate to clinical outcomes? I think this is a good evidence of that. I think they've done. The loss of function mutation is very common, is more common in East Asians, yet they continue to use Plavix quite, if you look at the East Asian journals, they tend to use Plavix quite liberally out there, even though they have a genetic variant. So and it doesn't lead to worse clinical outcomes always. So yeah, I think it's an area that requires a lot more study.
Okay, thank you.
Thunder, Achieng. Maybe I should just stay quiet.
Oh, no, I agree.
Thanks, Mitch, for the question. It's a question from Dr. Karnour, and so it just comes, to one of your situations like aspirin versus Plavix for long-term stable coronary artery disease. Any preference? Anyone wants to jump in and take that one?
Well, I guess it depends on the presentation. Just for long-term stable, I don't know, I suppose with everything that we've talked about during this session, you would almost want to go for ticagrelor, but I suppose then you want to assess the bleeding risk and everything else. And as was just discussed, even though there are these factors that we talked about during the session, not everyone is going to have a clinical outcome that actually is significant. And a lot of people actually are on Plavix and aspirin and are doing quite well. And also there's a lot of people who, for example, wind up having, atrial fibrillation or other things like that. And, there are other indications where ticagrelor isn't necessarily the best medication. So I don't think that this is to say that clopidogrel shouldn't be used as often as it is.
Greg, you're on. Do you have another question, or are we commenting on the same thing?
Can you hear me?
Yeah, go ahead.
Okay, so look, this platelet reactivity in vitro test is an in vitro test. It doesn't really translate for the vast majority of patients clinically. So I think we designed a test that doesn't really predict very well. What's happened in the field is that clopidogrel initially was thought to be more dangerous in bleeding. It's actually less bleeding compared to aspirin therapy. There's now emerging data that clopidogrel is going to replace aspirin as a single agent for antiplatelets right now. So I think you highlighted the very high-risk patients, those at risk for thrombosis, recurrent cardiovascular events, should be on dual antiplatelet therapy. What's probably going to happen is that we're going to use clopidogrel as our #1 antiplatelet agent over time over aspirin, and it looks like it's safer and better than aspirin. So that's my conclusion of a lot of this stuff. And the antiplatelet story is an in vitro study for the vast majority of patients. It's not that important. And I think in your high-risk patients, dual antiplatelet therapy. I'm not sure if that's what people think, but that's how things are evolving in my mind. I'd be curious how people's thoughts of that.
Comments from our panelists, speakers?
Yeah, I would agree with that. I think I see some other hands that are raised right now.
Okay, thanks, Greg. Dr. Turpie, you're on if you want to ask or comment. Irene, do you have a question or comment? I'm not sure if Dr. Turpie.
That was an error. That was an error. I'm sorry.
Oh, apology. Okay.
I think John Neary had a good question in the Q&A about why we are preferentially using ticagrelor in Hamilton when the large ISAR REACT 5 trial showed superiority of prasugrel.
I think John is on right now. I don't know if John, you want to expand on your question or you have another comment. If not, we'll allow.
I could. Can you hear me, Khaled?
Yeah. Go ahead, John. Thank you for.
Yeah. I mean, I can rephrase that. Ticagrelor was initially adopted in many centers over prasugrel because it was thought that the degree of superiority of ticagrelor versus clopidogrel in head-to-head trials was greater than that of prasugrel. But then they were compared head-to-head, and prasugrel appeared to clearly be superior. Moreover, prasugrel is once daily dosing, and you'd therefore think it's a lot more resilient to imperfect adherence in real-world settings. So why are we using ticagrelor at all?
Anyone have any thoughts?
I'd actually love to hear from someone in cardiology on this.
I personally am not as familiar with that. And yeah, it would be good to have some input. Maybe that's something we can bring to our cardiology colleagues at their rounds.
Yeah, I'm not sure, Greg, if you're on again, if you have any thoughts on this one, but I'm not sure if anyone else, I'm not seeing any other hands.
So this is actually a very confusing area, but basically we start off with the Capri trial way back when that Clopidogrel was better than aspirin and safer, and we forgot that data. Then we went to thrombosis of stenting, and the current generations of stenting is much safer, much better. So thrombosis of stents are less than before. Then we went to longer durations of therapy versus shorter durations of therapy. Then we found out bleeding is a major issue. So as you pointed out in all this area is that antiplatelets are not anti-thrombotic. They're good for acute coronary syndromes, but and predicting plaque rupture is very unpredictable. So what I think we need to think about is that there was some initial superior trials that suggested that newer antiplatelet agents were better. And so we're basically in a little bit of a messy situation right now. And I think, as you point out, is balancing bleeding risk versus thrombotic risk. And that's always a challenge. And I think for the older people, the frail people, 1 month of dual antiplatelet therapy and then followed by probably clopidogrel long-term is probably the best balance between safety and risk of bleeding. In patients who are young, who have recurrent thrombosis, then ticagrelor and aspirin would be the choice for long-term for forever. Their high risk of thrombosis and their risk of bleeding is lessened. Prasugrel came out to be superior later on, and it's just not available. So it's just not part of our equation on a regular basis. So I think it's just balancing the risk of thrombosis and the risk of bleeding. And you have lots of choices. I hope that helps a little bit. And also the generations of stenting has changed. The stents are much better now. They don't thrombose as much.
Thank you, Greg. Not sure if there's any other comments.
But you should also probably get Dr. Mita at some point in time to give his 2 cents. He's a guru when it comes to this. He, I think having his say on this would be a very important thing for everybody to hear about that, because it is an evolving area.
Good point. Thank you very much, Greg. Okay, there's a question, just clarifying question from Dr. Lim around the PCI studies. If all your patients there did undergo stenting, and were there like a single stent versus multiple stents, and whether the outcomes were different. Anyone wants to take that one? I'm not sure about that. I can't remember the data that you guys presented.
Yeah, I'm not sure if you're referring to the studies at the beginning or at the end. For the studies that I reviewed, it did not specify if there were stents or no stents and single versus multiple stents. And I'll let the other presenters talk about their studies.
Okay, thank you very much. That actually clarifies some that looks like it's not specified. There's a question from Dr. Priptani around the COMPASS study with aspirin and low dose Riva as an option in terms of post PCI. Have you come across any of that data?
I haven't come across any of that data, but that doesn't mean it's not out there. That would be an interesting question to assess.
Excellent, thank you very much. Looks like, I mean, more challenges. There are lots of challenges with this commonly used, very, very important treatment. I'm not sure, Dr. Kernow, we have, is this a new hand? I'm going to allow you to talk if this is a new hand, and then we would close. I think we went through that.
Sorry, I'm sorry, that's for old question.
Okay, all right, perfect. I don't want to miss you any comment you've had. All right. All right. Fantastic. I think this has been a very, very final comments from anyone? Any of our panelists, speakers? Any final comment?
No, it was a great talk. Generated a lot of discussion. That's the mark of a good talk.
Yeah, no, fantastic. Really well prepared, evidence-based, and generated lots of discussion and more questions to be answered. Which is the importance of these academic grounds. So thank you very much, our fabulous chief residents, and we'll wish everyone a great rest of the day. And we have a couple of minutes. Oh, I like that clapping hands and you think. Thanks. All right. Wish everyone a great rest of the day, and thank you very much for joining today. And thank you to our speakers.
Thank you.
Thanks, guys.
Thanks, everyone.